So let's talk about one specific type of acute polyneuropathy. So Guillain-Barré. We don't have that spelled out here, but it's Guillain-Barré. You also might see it called an acute immune demyelinating polyneuropathy or polyradiculoneuropathy. And it's an acquired demyelinating neuropathy. So we've talked about axonal findings, and then we talked about some of those myelinated fibers. What happens here is that because of some sort of inflammation, that myelin gets shot down, and so this patient very quickly begins to have this ascending type of weakness, often starting in the feet. You'll get numbness and weakness in the ankles and feet, and working its way up towards the rest of the body, sometimes even involving the face and the other cranial nerves. There is an association between this disease and certain infections, especially Campylobacter, which is one of those buzzwordy things that in real life, if you don't see the infection, don't rule this out. So in general, though, we're looking for acute symmetric weakness, usually of the ascending variety, with a lot of sensory findings to go with that. And I would say the sensory stuff often happens a little bit before the motor and the reflexes go.
Like a warning sign.
Exactly.
But who would know?
Well, yeah. Hopefully you guys when you see them in the hospital, right? So the next thing we might see, so on diagnosis, there's a couple of keys. So I would say for me the biggest key is going to be the clinical story that we just talked about. But you'll see evidence of demyelination. We don't do a biopsy because it takes too long to get that back. These people get sick within a few days. But we'll do something called the nerve conduction study, which you might see in the hospital, and we see evidence of demyelination, which just sort of as an advanced placement fact for you guys to know, is associated with a slowed response. We'll zap a nerve, we'll see what sort of a response we get from a muscle or another part of the nerve. It may take a little bit longer than we would expect for that response to come across the nerve. So you'll see that. We think of that slowing as associated with demyelination when we do that test. The other thing that you might hear about or even see is if you do a lumbar puncture, that's what LP stands for, you'll see this really weird finding where you'll have elevated protein and little to no white blood cells. So normal is like 0, basically. 0, maybe a handful, like 10. So if you get that sort of white blood cell count but a lot of protein, then you're wondering about Guillain-Barré in this clinical situation. It's more of a, this particular finding with a lumbar puncture is more of a supporting fact. So don't make your diagnosis completely based on that finding. But it is a helpful thing if you're hot on the trail of possible Guillain-Barré.
Just like everything else in medicine, it's a correlation of
Exactly.
different findings and not one thing.
Yeah, I've seen people make the mistake, honestly, of seeing just that finding sort of borderline and then jump to this diagnosis. And then when I see the patient later on, after they've left the hospital, I go, I don't know if that was what happened to you.
Yeah.
So the treatment for these folks, because it happens acutely, so there's two things medically. One is plasma exchange, which we talked about with our myasthenia patients.
That's right.
The other one is IV immunoglobulin again. So basically the same ideas. I think the bigger thing for both these patients and for your myasthenics who are in the hospital is supportive care. And the biggest thing is respiratory support. Because for both Guillain-Barré and for our myasthenic patients, it's the respiratory stuff. They'll have some difficulty breathing and pushing out air. That's what can kill them. Yeah, so we have to really keep a close eye on that. So I think we're about to close up. And so we've talked about muscle, neuromuscular junction, peripheral nerve, motor neurons, or neurons in general. Let's close with motor neurons. You guys talked about nerve roots in anatomy. So let's talk about motor neurons now. And the one disease that we'll talk about is amyotrophic lateral sclerosis, or ALS. So this is a progressive weakness. It's sort of random in the way that it starts. So we can start with a progressive weakness starting in almost any limb or even along the face with some of those bulbar signs we've been talking about with some of our other diagnoses. And it's a mix of upper motor neuron and lower motor neuron signs, and that's the buzzwordy thing. But for me, when I see these patients, I look for this almost randomly spreading progression of motor-only signs. So what things that we can see, so your lower motor neuron signs and your upper motor neuron signs, you'll see weakness, like we said, they can be kind of random. You can see atrophy to go with that. You can see fasciculations, which we don't have a video of it up here, but basically you ask someone to stay still and their muscle will just be twitching involuntarily. And those are typically lower motor neuron signs. But then the thing that you'll see with these patients a lot of the time are brisk reflexes. You tap a reflex very lightly and then you go, whoa, okay, that was not expected. So that's your mix of upper motor neuron and lower motor neuron signs right there. Over time, if they have bulbar involvement, so speech and swallowing can get involved. They'll also have some shortness of breath because the diaphragm, that muscle, can get affected as well. Unfortunately, it's progressive and we're still without a cure, although hopefully with some time we'll get better treatments. But the life expectancy right now is about 4 years on average. And death is usually due to respiratory failure. There's only one FDA-approved medication, or there's two, I should say, two FDA-approved medications for that, but they are thought to slow things down rather than reverse things for this particular diagnosis. So hopefully over the course of time, maybe by the time you guys are full-on attendings, we'll have some more options for these patients. And I'm actually optimistic that we will.
Yes, and it can involve anybody, whether you're a baseball player like Lou Gehrig or a prominent scientist like Stephen Hawking.
Yeah. All right. But I think that's it. Anything else?
That's all for me as well. And please pay attention to your clinical and pathologic correlations and try to understand why things are happening rather than just memorize stuff, and you will be fine.
All right. So we'll see you guys over at the PI. All right. We'll see you then.
Thank you.
All
Take
right,
care,
bye.
guys. Bye.